The hearing will come to order. I would like to welcome everyone to today's hearing. The topic today is rural health care, which is a critical issue for virtually every member of this committee and so many others. I've long considered it a special mission to create the same rural payment opportunities that many of our nation's urban counterparts enjoy. Representing a Western state, I understand the challenges our rural hospitals and providers face to deliver high-quality medical care to families in environments with more limited resources. In the Senate, rural health care policy boasts a long history of collaboration and cooperation on both sides of the aisle. Take, for example, back in 2003 when we passed the Medicare Modernization Act. The MMA included a comprehensive health care package tailored specifically with rural communities, hospitals, and providers in mind. The MMA finally put rural providers on a level playing field with their neighbors in larger communities. The law also put into place common sense Medicare payment provisions that help isolated and underserved areas of the country provide access to medical care as close to home as possible. However, while the vast majority of rural health payment policies enacted in the MMA were permanent, some were only temporary. In the years following, these temporary provisions have become known as the Medicare extenders. As many of us know, the problem with extenders is that annual debate over necessary funding often takes priority over developing a more robust strategic plan for the future. Although some partisan and bipartisan healthcare policies have since altered Medicare payments, many rural and frontier healthcare providers still face significant obstacles attempting to successfully participate in Medicare's delivery system reforms and bundled payment arrangements. And while these changes continue to emphasize new ways to pay providers, Medicare's existing strategies to preserve access to health care in rural areas still rely on special reimbursement programs that either supplement inpatient hospital payment rates or provide cost-based hospital payments. Now, these special payment structures may work just fine in certain parts of the country, but even with a wide range of special Medicare rural payment programs, some smaller communities are home to hospitals that still find it hard to achieve financial stability. The reasons, as we will learn from the expert witnesses on the panel today, are complex and multifaceted. For example, when compared to their urban counterparts, on average, the 4 million Medicare beneficiaries living in rural areas, rural and frontier areas, are less affluent, suffer from more chronic conditions, and face higher mortality rates. To make matters worse, small rural hospitals continue to be more heavily developed or dependent on Medicare inpatient payments as part of their total revenues. At the same time, we are seeing a steady nationwide shift away from inpatient care to providers offering more outpatient services, it seems to me. Many rural hospitals serve as a central hub of community service and economic development, but some struggle to keep their facilities operating in the black in order to meet local demands for a full range of inpatient, outpatient, and rehabilitation services. Resolving these issues is no easy task. Clearly, for some communities, Medicare's special rural payment structures, I guess I should say, may stifle innovations that could pave the way for more sustainable rural healthcare delivery systems. One consistent theme that we will hear from our witnesses today is the need for flexibility. They're not asking Congress for a one-size-fits-all federal policy. They want the flexibility to design innovative ideas that are tailored to meet the specific needs of the communities they serve. They need the federal government to support data-driven state and local innovations that have the promise to achieve results, increasing access to basic medical care, lowering costs, and improving patient outcomes. But the federal government cannot tackle this challenge alone. While I was pleased to see CMS release its rural health strategy earlier this month, I believe that this administration, led by HHS Secretary Azar, still needs to improve coordination across the agencies within the department to help prioritize new rural payment models, while also reducing regulatory burdens on rural and frontier providers. State and local officials must be aggressive in their efforts to design transformative policies and programs that meet their unique rural health care needs. And the federal government really needs to listen. We should listen to what these folks have to say and how we can, what some of the solutions really are. In my view, states should be the breeding ground to test new ideas. However, it is not sustainable for every small town to have a full-service hospital with every type of specialty provider at its disposal. That is why it is so important for rural communities to work together, share resources, and develop networks. The federal government must continue to recognize the important differences between urban and rural healthcare service delivery and respond with targeted fiscal responsible solutions. By pooling our knowledge, expertise, and financial resources, we can work together to develop targeted payment policies that ensure appropriate access while also protecting Medicare beneficiaries and American taxpayers. Now, I'm looking forward to hearing some of those innovative ideas from our witnesses here today. But before I turn to our ranking member, Senator Wyden, I want to bring one important item to the attention of the committee. The Medicare Payment Advisory Commission, otherwise known as MedPAC, has submitted a statement for the record outlining the Commission's latest recommendation aimed at ensuring access to emergency development services for Medicare beneficiaries living in rural communities. I encourage all members to review MedPAC's statement and ask that it be made part of the official hearing record. With that, let me now turn to my partner on this committee, Senator Wyden, for his opening statement.
Thank you very much, Mr. Chairman. And first, I want to say right out of the gate that I think it is very doable to produce a bipartisan product here. We did that with respect to chronic care. We did that with respect to 10 years for CHIP. We did it, by the way, in the rural area. It's related to medical extenders, where we were talking about literally life and death matters like ambulances. So I want to make sure that we understand that on this side, we think it is very doable to come up with a bipartisan product. Each year I hold open to all town meetings in every rural Oregon county, and there I meet with many leaders from the healthcare field. And they tell me there are a few potential healthcare calamities that have them afraid for what is coming down the pike. First, many in rural communities feel that there is a wrecking ball headed their way because the Trump administration and half of Congress have spent the last 15 months trying to pull out all the stops to make enormous cuts to Medicaid. The president's budget, which of course is a public document, indicates that another assault could be coming. The fact is, Medicaid is a lifeline for rural hospitals and patients. And those who have been on the front lines will tell you, those who've been out there for decades, that if you want to turn rural America into a sacrifice zone where hospitals shut down and people can't get the health care they need, the fastest way to do it is by slashing Medicaid. Second, people in rural areas today feel that their local hospitals are already teetering on the brink of closing their doors. And if the local hospital goes under, that means no more emergency departments available in a crisis. Now, this isn't a far-off theoretical problem. Decades ago, back when getting routine health care more often meant spending multiple nights in a hospital inpatient bed, rural hospitals were much more secure. They could afford then to maintain the emergency department. But that service may be on the ropes now because rural hospitals are under such huge financial pressures. Offering a variety of inpatient services and keeping that emergency room open is extraordinarily expensive. And at the same time, more and more Americans are turning to outpatient settings for chronic care, rehab, and routine surgeries. Since 2010, 83 rural hospitals have closed their doors, and hundreds more are in dire straits. In fact, rural services have been closed since 2010, 83 rural hospitals. Bottom line, when you live in a big city like Portland, Chicago, or Los Angeles, you take it for granted there's always going to be an emergency department nearby. But rural Americans who fear their hospital will be the next to close are left wondering what's going to happen if their son or daughter breaks a leg in a high school basketball game. I heard exactly that kind of concern just a couple of weeks ago in rural Oregon. Where would the family go if an older loved one suffered a stroke? Would they get to a hospital in time if dad suffers a heart attack? Keeping these hospital emergency departments open is a key challenge when it comes to rural health care. In my view, it's step one when you're working to prevent rural America from turning into that sacrifice zone where people can't get the care they need. And I'll just close by this point. I've already indicated I think we can produce a bipartisan product here. I mean, a country as wealthy as ours looks like we spent about $3.5 trillion last year on health care. For that amount of money, you could practically send every family of four in America a check for $40,000 and say, here, get health care. It ought to be possible to guarantee that rural Americans are not on the outside looking in. Thank you, Mr. Chairman. Looking forward to working with our colleagues and getting that bipartisan product.
Well, thank you, Senator. Let me just set the record straight. The decline in rural hospitals started long before Medicaid expansion and prior to the Trump administration, of course. Rather than touting Medicaid expansion or blaming Trump, I hope we can set politics aside and evaluate whether Medicare and Medicaid are yielding an appropriate federal response to assist states and communities. That is, after all, the purpose of this bipartisan hearing. We cannot just spend more money in Medicaid and expect to solve every problem. So I look forward to a continued discussion with our expert witnesses about what more can be done to ensure federal dollars are being spent judiciously and wisely to help our rural hospitals and providers. So we need to do that. Now, I would like to extend a warm welcome to each of our 5 witnesses today. I want to thank you all for coming. Today, we will briefly introduce each of you in the order you are sent to testify. First, we will hear from Dr. George H. Pink, the Humana Distinguished Professor in the Department of Health Policy and Management at the Gillings School of Global Public Health, Deputy Director of North Carolina Rural Health Research Program, and the Senior Research Fellow at the Cecil G. Ships Center for Health Services Research, all of the University of North Carolina at Chapel Hill. Prior to receiving his PhD in corporate finance, Dr. Pink spent 10 years in health services management, planning, and consulting. Dr. Pink holds a bachelor degree in marketing from the University of Calgary, a master's degree in health administration from the University of Alberta, and a PhD in corporate finance from the University of Toronto. Our second witness, Dr. Keith J. Mueller, will be introduced by my good friend and fellow committee member, Senator Grassley. Senator Grassley, if you'd like to, you could proceed right now with your introduction.
Yeah, before I do that, since rural hospitals have been brought up, I'd like to point out to my colleagues, and particularly to Senator Wyden, because he brought it up. I have a bill in, it goes by the acronym REACH, that I think about half of the Senate's co-sponsoring, and in fact, you may even be a co-sponsor of it. I hope people look at that, because that is an alternative to the possible closing of some rural hospitals. It's my privilege to welcome another Iowan, Dr. Keith Muller. Dr. Mueller is a renowned researcher who is an expert about rural health care. He is the interim dean of the College of Public Health and a professor of health management and policy at the University of Iowa. He directs the RUPI, which is an acronym for the Center for Rural Health Policy Analysis at the University of Iowa. Dr. Mueller has published more than 220 scholarly articles and has received national recognition for his rural healthcare research. Welcome, Dr. Mueller.
Thank you, sir.
Yeah.
Next to speak will be Miss Konnie Martin, and she'll be introduced by our friend and colleague, Senator Bennett. Senator Bennett.
Thank you, Mr. Chairman, and thank you so much for holding this hearing. Rural communities have long been struggling with the scarcity of healthcare providers and facilities. This has exacerbated the challenge of responding to the opioid epidemic, which has hit rural Americans particularly hard. I'm pleased to introduce my fellow Coloradan, Konnie Martin, the Chief Executive Officer of San Luis Valley Health, an independent nonprofit health system in Alamosa, Colorado. Ms. Martin has been working to serve the healthcare needs of rural Coloradans in the San Luis Valley for more than 30 years. Prior to being named CEO in 2013, Ms. Martin served as the San Luis Valley Health's Chief Operating Officer. She completed advanced leadership training at the Regional Institute for Health and Environmental Leadership at the University of Colorado, also the Healthcare Executive Program at the UCLA Anderson School of Business. She graduated from the University of Arkansas at Monticello. Ms. Martin also plays a pivotal role in the local community. She is the Adams State University Presidential Search Committee's community liaison and a member of the Alamosa County Economic Development Corporation. I look forward to hearing Ms. Martin's testimony. Thank you, Mr. Chairman.
Thank you, Senator Bennett. Now, our fourth witness to speak will be Ms. Susan K. Thompson, who is also from Iowa, and who will also be introduced by Senator Grassley. So, Senator Grassley, take it away.
Sue, it's my privilege to introduce you to the committee. She is Senior Vice President of Integration and Optimization for Unity Point. Sue is also the CEO of Unity Point Accountable Care, a nurse by training, and she's the first Iowan to be named to the Medicare Payment Advisory Commission, as you said, Mr. Chairman, known as MedPAC for short. Sue's professional achievement and expertise will speak for themselves. However, I'd like to say that a part of her legacy is sitting behind her today. So I'm going to talk about her family that's involved in rural health care as well. Nate Thompson is Sue's son. Nate is the CEO of Story County Medical Center, a critical access hospital in Nevada, Iowa. Ashley Thompson is Sue's daughter-in-law and Nate's wife. Ashley is government relations specialist for Unity Point. Dr. Caitlin Thompson is Sue's daughter. Dr. Thompson is a psychiatrist working with the Berry Hill Center for Mental Health, a community mental health center in Fort Dodge, Iowa. And Chad Bedke is Sue's son-in-law and Dr. Thompson's husband. Chad is the director of physician billing operations for Unity Point Clinic. So, Sue, it seems to me like your family is as much involved in rural health care as you are. Welcome to the committee.
Well, thank you, Senator, for providing that kind introduction. Our final witness will be Dr. Karen M. Murphy, who will be introduced by our good friend and colleague, Senator Casey.
Thank you, Mr. Chairman. Privileged to introduce Dr. Murphy. Dr. Murphy is Chief Innovation Officer at Geisinger Health System. I know her from our
hometown, and she has a long record of service in healthcare. She served our state as Pennsylvania Secretary of Health. She was president and CEO of the Moses Taylor Healthcare System, which is just blocks from my home. Her education is substantial, Doctor of Philosophy and Business Administration from Temple's Fox School of Business, an MBA from Marywood University. My mother and my daughter and some my sisters would want me to mention Marywood. A Bachelor of Arts from the University of Scranton, and a nursing diploma. So whether it's nursing itself, which was her calling, as well as a real commitment to the reform in the healthcare delivery system, in so many ways, Karen has brought a passion and a degree of excellence to these issues that I think is unmatched. So, Karen, Dr. Murphy, welcome.
Well, thank you, Senator Casey, for rounding off our introductions. I would also like to thank the witnesses for being here today, and in particular, thank them in their testimony and in advance for their patience and their flexibility as members will be moving in and out of today's hearings because we have other markups going on right now as well. I have 2 or 3 markups going on right now. Personally, I must have to leave to attend a Judiciary Committee markup. And now with all that out of the way, Dr. Pink will begin with your opening remarks, okay? Dr. Pink.
Chairman Hatch, Ranking Member Wyden, and members of the committee, thank you very much for the opportunity to testify today on behalf of my colleagues at the North Carolina Rural Health Research Program and the Gilling School of Global Public Health at the University of North Carolina at Chapel Hill. We research problems in healthcare, rural healthcare delivery, and are funded primarily by the Federal Office of Rural Health Policy. I am here to discuss what we know about rural hospital closures, and I will start with an all-too-common story. Coalinga Regional Medical Center in Coalinga, California, is a 24-bed acute care hospital with 200 employees. On May 1st, it announced that after 18 months of losses totaling $4.5 million, it is insolvent and will close all services in June. The closure will leave residents in the rural Fresno County city of 17,000 people without an emergency room. The nearest hospital is Adventist Health in Hanford, which is over 40 miles away. Coalinga will be the second hospital in the San Joaquin Valley to close in the past 6 months. Tulare Regional Medical Center, a 112-bed hospital, closed 6 months ago. Across the country, 125 rural hospitals have closed since 2005, 83 since 2010. Why is this happening? Many reasons, but long-term unprofitability is an important factor. Years of losing money results in little cash, debt payments that can't be made, charity care and bad debt that can't be covered, older facilities, and outdated technology. Why do they lose money? Small rural hospitals serve patients who are older, sicker, poorer, and more likely to be or underinsured. They staff emergency rooms, often in communities with small populations and low patient volumes. Combine this with reimbursement reductions, professional shortages, and many other challenges, and you can see why I prefer being a professor to a rural hospital executive. What happens after a closure? Some convert to another type of healthcare facility, but more than 1/2 no longer provide any healthcare services. They are parking lots, empty buildings, and apartments. Patients travel an average of 12.5 miles more to the next closest hospital, but many travel 25 miles or more. For the old, poor, and disabled, and who cannot afford or do not have access to such transportation, these distances can be very real barriers to obtaining needed care. Who is most affected? We have investigated communities served by rural hospitals at high risk of financial distress because they may be the next facilities to close. These communities have significantly higher percentages of people who are Black, unemployed, lacking a high school education, and who report being obese and having fair to poor health. In other words, vulnerable people. If the hospitals that serve these communities reduce services or ultimately close, already vulnerable people will be at increased risk. What can be done? We can try to improve what we have by exploring ways to better target Medicare payments at rural hospitals in greatest need and where closure would have the greatest adverse consequences on the communities. Preferably, we should develop something new. At meetings around the country, the most common frustration I hear is the lack of a model to replace a distressed or closed hospital. We have acute care, inpatient model hospitals with emergency rooms on one end, and we have primary care clinics on the other end. We need something in between. There is no shortage of innovative ideas. 8 to 10 new rural models have been proposed by various organizations. The profound challenges facing providers that serve rural communities are not going away. We need to step up the pace of innovation, faster evaluation, implementation of new models, and development of the Medicare policies and regulations that will allow and sustain them. Thank you again for the opportunity to discuss these issues with you today, particularly because during the past 35 years, some of the most innovative and effective developments in rural health policy have emerged from the Senate Finance Committee.
Well, thank you so much. We appreciate having you here, and we appreciate your expertise. Mr. Mueller, we'll turn to you now.
Chairman Hatch, Ranking Member Wyden, members of the Finance Committee, thank you for this opportunity to share my perspectives on key issues in rural health and related policy considerations. While some things have changed in the 30 years I have been conducting rural health research and policy analysis, the underlying dynamics remain much the same. But we have new tools both in healthcare delivery and through public policy to help us continue our quest to establish a high-performance health system in rural America. We've had an interesting ride in policy debates and developments over that time, including weathering the aftermath of creating prospective hospital payment in the 1990s, considering healthcare reform in those years, major changes in Medicare payment and benefits, changes through the Patient Protection and Affordable Care Act, and now a renewed and welcome discussion of what we should be doing to best serve the needs of rural residents. I've benefited from exchanges with this committee and others throughout, starting with the conversation Senator Roberts and I had when I testified as part of the Rupri Health Panel, which I now chair, to the House Committee on Agriculture in 1993. We provided analysis of 5 reform proposals, including the Health Security Act, by assessing their impacts on key rural considerations. Senator Roberts may remember, and it looks like he does, sharing appreciation for the straightforward analysis that we provided, which helped give me the confidence to continue bringing forward the best we can offer from policy analysis. Of course, then Representative Roberts may not have liked the thumbs up, thumbs down table of our conclusions that my local newspaper provided displayed during the hearing. The Rupri Health Panel launched in 1992 to bring rural dimensions front and center in policy discussions. We provided analysis during development and implementation of major national policies, including the Balanced Budget Act of 1997, the MMA that Senator Hatch referred to in 2003, and of course PPACA in 2010. We provided feedback to this committee and others during policy formation and followed up with analysis of rural impacts of new policies, including calling attention to unintended consequences of the BBA in 1997, before that term was as ubiquitous as it is now. I've come to appreciate the nexus of what we do in the research community with the concerns and needs of our colleagues developing healthcare services. As president of the National Rural Health Association in '96, I represented the needs of rural providers in policy discussions. One of my funded projects in the early 1990s was working with providers in Nebraska and Iowa to develop a template for a provider-sponsored Medicare Plus Choice plan. Much of my research now involves visits to rural healthcare organizations to understand the implications of Medicare and other policies on what they do. My engagement and that of the Rupri Center, the Rupri Health Panel, and the Rural Telehealth Research Center based in Iowa, and collaborations with others covers a host of specific topics of interest to this committee, including Medicare Advantage, rural ACOs, rural pharmacy, implications of changes in healthcare delivery and organization, delivery system reform initiatives, and the evolution of the marketplace in health insurance coverage, and the role of telehealth. My written testimony includes specific research findings on some of those topics, along with policy considerations. I would like to share some important questions to consider for the future of the Medicare ACO program. Are there benefits other than savings related to changes in delivery models that help achieve the triple aim of patient experience, better health, and lower costs? Should there continue to be different tracks? Should variations of advance payment, perhaps as grants, continue to be available? Finally, what is the next iteration of payment reform that builds from the experiences of ACOs, perhaps global budgeting that we'll hear about later? I now offer the Rupri Health Panel's 5 rural considerations for policies designed to encourage delivery system reform. 1, organize rural health systems to create integrated care. 2, build rural system capacity to support integrated care. 3, facilitate rural participation in value-based payments. 4, align Medicare payment and performance assessment policies with Medicaid and commercial payers. And 5, develop rural appropriate payment systems. In general, policies should be sensitive to the rural practice environment, including population density, distance to providers, and the need for infrastructure investment. New models can build on the strengths of the rural system, notably primary care. Thank you for this opportunity, and I look forward to your questions.
Well, thank you. We appreciate having your testimony here today. So we'll go to Ms. Martin then at this point.
Thank you for the opportunity today to share our healthcare story. I am the CEO of a small healthcare system located in the San Luis Valley, which is a rural, agriculture-based community in southern Colorado. We serve 6 counties, an area roughly the size of Massachusetts, and are the safety net for our nearly 50,000 residents. 2 of our counties are the poorest in Colorado. Nearly 70% of our patients are covered by Medicare or Medicaid, with less than 20% having commercial insurance. With this challenging payer mix, we are a constant struggle to remain financially viable. SOV Health and the rural hospitals around the country are appreciative of this committee's commitment to rural communities, and we're hopeful that meaningful help is on the way. Our system is comprised of a 49-bed sole community hospital and a 17-bed critical access hospital. We operate 5 rural health clinics, 2 of which are provider-based. This past year, we provided 2,500 hospital visits, 58,000 outpatient services, and over 65,000 clinic visits. We are a level 3 trauma center and the only facility that delivers babies, provides surgery, or has any type of specialty care for 120 miles in any direction. We serve veterans, farm workers, college students, tourists, and our own friends and families. We are a resilient and creative team of healthcare providers. We are the largest employer in our region with a staff of over 800. Many of them have lived in the community their entire lives and their families for generations. As for me, I moved to the Valley in 1985, and I began my healthcare career in an entry-level IT position, back when the personal computer was new technology, and have worked my way into the current CEO role. Our staff struggles with the cost of meeting regulatory requirements, which are often different and sometimes conflicting across payers. Our system must report on dozens of measures for the Medicare Quality and Pay for Performance programs. However, our private insurers ask us to report yet more, sometime on the same topic, but using a different definition. This complex and confusing data reporting takes time away from what really matters, which is delivering on our healthcare mission. Recruiting and retaining a qualified workforce is another challenge for rural providers. We've been fortunate to form partnerships with local and state schools that help develop and maintain our workforce. Specifically, we have multiple Grow Your Own programs, from paramedic training to hosting medical students, internships, and mentoring those who are pursuing a healthcare MBA. We collaborate with the local community health center to host a rural residency training track program. We are set to have the first 2 physicians complete this training in June of 2019. We do have our workforce success stories to celebrate as well, with 2 family medicine physicians in our system who returned to their childhood homes to care for friends and neighbors. And we have a physician who came during college to serve as a volunteer in a local shelter, and today he's a surgeon in our organization. Rural communities pride themselves on hard work and taking care of their own. However, federal payment systems and delivery models must recognize the unique circumstances of providing care in a rural community, and they must be updated to meet the reality and challenges of how healthcare is delivered today and into the future. About 10 years ago, the critical access hospital that is part of our system now approached us for help. Nearing closure and in dire financial condition, we entered into a partnership to provide management services and financial support. In 2013, this critical access hospital fully merged into the system that is today San Luis Valley Health. This type of arrangement prevented a hospital closure, but such partnerships are not available to many rural hospitals. We see the result with hospital closures across the country, and today 12 rural hospitals in Colorado are operating in the red. Therefore, I'm here today to ask for your support and consideration for new financial models that consider our needs, including the creation of a 24/7 rural emergency medical center designation, such as the American Hospital Association has recommended and Senator Grassley has championed. And I ask you to provide appropriate resources, flexibility, and ongoing dialogue with those of us in rural America who stand ready to innovate, work hard, and meet the current challenges of caring for our friends and neighbors. In a country as great as ours, where you live should not determine if you live. Thank you for your remarks.
Thank you so much. We'll turn to you now.
Thank you and good morning. Thank you for this great opportunity to address the committee on several of the challenges facing healthcare in rural America and offer up some ideas for potential solutions. Now, I would be remiss if I did not take this opportunity to publicly thank our senator from Iowa. Senator Grassley has made access to quality healthcare in rural regions of our country a relentless priority. Thank you, Senator, for everything you do for Iowa and for our country. Before assuming my job at the corporate office of Unity Point Health, I was the CEO of a small health system affiliated with Unity Point in Fort Dodge, Iowa. Trinity Regional Medical Center is a 49-bed hospital, including a group of physician clinics and home care services that over the years have held the designations of a 200-bed PPS hospital, a sole community hospital, a rural health clinic, and most recently, a tweener, as it participates in the Rural Demonstration Program. Trinity has formal management agreements with 5 critical access hospitals and close referral relationships with sister Unity Point metropolitan markets, including Des Moines. But possibly the most unique experience Trinity has participated in to date has been as a Medicare Accountable Care Organization, an ACO. Classified as a pioneer ACO, Trinity took responsibility for improving the quality and lowering the total cost of care for approximately 10,000 Medicare beneficiaries attributed to them in this rural Northwest Iowa community. They did this successfully and continue to do so as a next generation ACO. It is through this work the challenges facing rural health communities, hospitals, and providers have become so palpably clear to us. The first challenge to highlight is the dichotomy in incentives that exist between those who operate under total cost of care programs like ACOs, Medicare Advantage plans, and bundled payment programs, and their rural counterparts who operate under fee-for-service, cost-based reimbursement methods. While the former looks to keep members healthy and out of the hospital, the latter is rewarded when hospital beds are full of Medicare patients. If the two groups worked in isolation of each other, this might work, but they do not. They are intrinsically woven together. The beneficiaries attributed to the Trinity Pioneer ACO move in and out of the rural facilities in the region. When regarding value-based payment models, the rural groups would ask, where do we fit in? And to date, the answer to that question has been, you don't. The policy approach has been to exempt them from value-based policy altogether. We submit this approach is not working and needs to change. Rural healthcare can fit into value-based payment models. So you wonder, is Unity Point Health advocating that cost-based reimbursement be deconstructed? And to that we answer no. We are requesting it be renovated. This brings me to the second challenge I must highlight, and this challenge is the greatest: access to healthcare services in rural areas. Bringing quality care to rural Americans comes at a cost, and the cost is distinct from the actual provision of the medical service. These additional unique costs relate to the time and the distance from major service centers, lack of comprehensive community services, and healthcare workforce dead zones. We propose the renovation of healthcare delivery in rural areas include a value-based component tied to quality medical outcomes and expenditures, and that a separate and distinct payment structure is developed for the portion of cost-based reimbursement that pays for the costs associated with access in rural areas. While our written testimony goes into greater detail how such a system could be structured, I offer you some playful do's and just one don't as we design this type of system. The do's. Do encourage the CMS Innovation Center to develop pilots that test Medicare Advantage programs designed to work in rural markets like Iowa. We see great potential for Medicare Advantage to bring the benefits of population health methods to rural areas. Do design ACO benchmarks to accommodate for the additional cost of bringing access to rural markets. And do support bills like the REACH Act that allow rural hospitals to transition to new designations designed to meet modern needs. And do continue to allow telehealth practice to extend the reach of our in-person providers. And with the utmost respect, just one don't. Don't embrace a policy that allows freestanding ambulatory surgery centers to establish residence in rural markets and cherry-pick patients by procedure, further straining the viability of community hospitals. I challenge you to find one for-profit freestanding ASC that has an emergency room. In closing, healthcare entities are the backbone of many of our rural communities. We need our rural healthcare delivery systems to be viable. We need them to make the transition to rural healthcare access centers we know they can become. Thank you for this opportunity to share these views.
Thank you, Ms. Murphy. We'll turn to you. You'll be our final witness.
Chairman Hatch, Ranking Member Wyden, and members of the committee, thank you for inviting me to testify today about rural hospitals. In addition to my clinical background, which you've already heard, I spent 2 years at CMMI before assuming my role as Secretary of Health, working on the State Innovation Models Initiative. Today, I'd like to share the development of an innovative payment and delivery model that was developed when I served as Secretary of Health in Pennsylvania. I began my tenure as Secretary of Health assessing the status of the healthcare delivery systems in Pennsylvania. I was struck by the financial instability of the rural hospitals. I found that in research, I found that the situation in Pennsylvania was being replicated across the country. Pennsylvania has the third largest rural population in the United States. 67 of our 169 hospitals in Pennsylvania are in rural communities. More than 58% of those hospitals in rural areas have mounting financial pressure, resulting in break-even or negative operating margins. We began to look for a solution. After having worked on the Maryland all-payer model while at CMMI and seeing the impressive results, we decided to design a similar model for rural hospitals in Pennsylvania. We worked collaboratively with CMMI on designing the model. I would also like to acknowledge Senator Casey and his office's support as we designed this model. The design period was launched in January of 2017. The objective of the model are to provide a path to improving health and healthcare delivery in rural communities. The model changes the way participating hospitals will be reimbursed. The model replaces the current fee-for-service system with a multi-payer global budget based on the hospital's historic net revenue. Like Maryland, the payment model in Pennsylvania is designed to include all payers. However, it was necessary to develop a new methodology since Maryland has the authority to establish hospital rates and Pennsylvania does not. The model moves rural hospitals from focusing on inpatient-centric healthcare services to a greater focus on outpatient-centric healthcare services with an emphasis on population health and care management. It replaces the current fee-for-service system with little emphasis on quality and safety to a payment model that includes direct incentives to improve quality and safety and eliminate subscale service lines. Rural hospitals are encouraged to move from traditional care models delivered directly on site to innovative care models that are enabled by technologies such as telehealth, video conferencing, and remote monitoring. The vision is that rural hospitals will invest in care coordination, such as reaching out to patients who frequently use the emergency room services and connecting them with the provider. It also includes population health and preventative care services, such as chronic disease prevention programs and behavioral health initiatives, including those targeting substance abuse disorder, with the expansion of medical homes to include medication-assisted treatment programs. Participating hospitals will have the ability to invest in social services that address community issues that lead to detrimental health outcomes. Based on the global budget, participating hospitals are expected to develop a transformation plan that could outline an innovative approach to improving health and healthcare delivery for the communities they serve. They're encouraged to work with community agencies such as United Way Area Agencies on Aging, Drug and Alcohol Treatment Centers, to develop services based on their community needs. To provide participating hospitals with transformation support, Pennsylvania plans to create a Rural Health Redesign Center. CMS has entered a cooperative agreement with Pennsylvania to provide up to $25 million over 5 years to support the Rural Health Redesign Center. This will provide a way to deploy capabilities to support all participating hospitals. Pennsylvania is planning to engage 6 hospitals in the initial performance year, gradually expanding to 30 rural hospitals in Pennsylvania. At Geisinger, we are a participant in the initial phase. Dr. David Feinberger, Geisinger's CEO, has been a staunch supporter of the initiative since its inception, as it builds on our vision for building a healthcare delivery system that focuses on improving health and value creation for each community we serve. We are looking forward to working with the state on this very important initiative. The financial challenges of rural hospitals today are the result of a changing healthcare industry. They may not be able to offer the same services that they did in the past, but it is possible that they can be leveraged to improve the health of those residing in rural communities. Next week, I'll be speaking at the Global Budgeting Summit at Johns Hopkins University. 26 states have registered to participate. The federal government has the opportunity to engage additional states in the Pennsylvania rural health model. Implementing across diverse states would give us the opportunity to evolve this innovative payment and delivery model. Thank you for your interest in aiding rural hospitals. I too believe rural communities deserve access to health care, and we must continue to work to identify innovative approaches that are a pathway to that goal.
Well, thank you so much. I think this testimony has been very interesting today. Let me just start with you, Ms. Martin. And in your testimony, you referenced times when your hospital system has been on the verge of financial crisis in the past. How did you leverage resources and streamline service delivery so that or operation lines to stay financially viable? And can you talk about what you think an appropriate Medicare margin should be for small nonprofit rural hospitals like yours?
Thank you, Senator.
Yeah.
I think it's interesting when you talk about margins for rural hospitals. I think any margin would be helpful to so many rural hospitals. I think for my system, located in the rural part of Colorado, if we can be in a margin area of 3 to 5%, we consider that a very successful year. And so I think different areas have different needs. It so much depends on your infrastructure and what you need to replace as far as equipment and facilities go. So I think for our system and my perspective, that's the margins that we're trying to achieve. But so many times we are under 1% or sometimes in the negative. I think what we did initially over these past few years is put our 2 systems of care together, the Critical Access Hospital and our Soul Community Hospital. And we did use the economies of scale. You know, we have one CEO for that rural system of care. We have one finance department. We share a lot of services between our 2 organizations, and that makes it cost effective to run the different departments. You know, we have a person who is an expert in laboratory or a person who's expert in imaging, and they help a larger organization when you can divide them across a couple of communities. The other thing we do is we're just very frugal. I think in rural America, we're very thoughtful about what we buy. We don't provide services that our community doesn't need because we don't have that luxury. We have to match our services to the needs of our community. We have built our primary care base over these past few years, and that has made a substantial difference with keeping our care close to home. And we've added specialty services that are the highest need for our patients and our community. For instance, we've added oncology services in the past 3 years. We started out with a model where we brought a specialist a day or two a month, and we built that to where we could have a full-time provider. I think part of our challenge is one single specialist in a rural community. You know, you have to have the connections to have coverage and support for that individual. So those have been some of our strategies. We're not a lucrative health system at all.
Well, thank you. Let me go to you, Dr. Murphy. First, let me say that there's a lot of excitement around the Pennsylvania rural health model. It clearly holds great promise. And I'm personally pleased to see CMS working with states to design innovative rural health care payment strategies. Is there any concern under Pennsylvania's new multi-payer global budget and payment method that rural hospitals might lose incentives to be efficient in providing health care services? And secondly, how do you think your state's rural hospitals will figure out ways to lower costs and improve health outcomes if they already know what they're going to get paid for procedures under the global budget?
Well, thank you, Senator. And I think the challenges, which is why I recommend that CMMI look to expand the test. It is a test to determine if we can successfully transform rural hospitals in a way that makes that is efficient and improves population health as well as healthcare delivery services. There is a monitoring component within the global budget methodology that will check. The model is being evaluated from day one that will determine the appropriateness of the services and the inability for unintended consequences to occur. So that's built in within the test of the model. But I think the goal here, the difference is there's a transformation plan that goes along with the global budget with monitoring metrics throughout the life of the global budget. So the hospital is going to be very tightly monitored as we go through implementing the global budget. I can assure you that certainly Medicare would be concerned about that, as would be all the other commercial payers. So I believe the model is robust in the way that it will measure for those unintended consequences.
Well, thank you. Let me turn to Senator Wyden.
Thank you very much, Mr. Chairman. I think this has been a terrific panel. And next week, when I have opened everybody town meetings in Prineville, Paisley, and Joseph, Oregon, I am going to remember what you said, Ms. Martin, that where you live should not determine if you live. And I can just tell you, I looked around the room and practically the whole place got whiplash when you said that, because that really sort of sums up the challenge. Colleagues, let me give you my sense of where we are in terms of the bipartisan possibilities going forward. We had the Bipartisan Budget Act. We got 5 years additional funding for several important programs for rural communities, extending the Medicare Dependent Hospital Program, increasing payment for low-volume hospitals, and as I touched on earlier, the ambulance add-ons. So that at least gives us some measure of predictability for the next 5 years. But it seems to me we've really got some heavy lifting to do in the next 5 years. I think we understand this calamity did not arrive on us in 15 minutes. We're not going to solve it in 15 minutes. So what I would like to do for purposes of kind of going forward in a bipartisan way here as we move under the efforts of colleagues on both sides is I'd like to just go down the row and have each of you give me what would be your top priority for Medicare as it related to longer-term stability for rural providers and particularly for rural seniors in our country, because we know that you have a disproportionate number of seniors in rural communities. So right down the row, top priority for Medicare for this kind of long-term stability that we have a chance to work on because we got at least a little predictability for the next 5 years. So just go right down the row.
Thank you, Senator. We have talked to people in communities where rural hospitals have closed, and almost always the first thing we hear is the disappearance of the emergency department, the emergency room. So I would say my top priority is maintaining access to emergency care.
Good. Mr. Muller.
I would say mine would be building that integrated system that I talked about that would include non-hospital based services, particularly both post-acute care after a hospitalization and care for the elderly with chronic conditions, which was in part addressed by the Chronic Care Act. We need to move forward with some of the innovations that are coming out of that.
Good. Ms. Martin.
The flexibility to develop a model in each rural community that meets their needs so that they can keep emergency care and can keep services.
What would that's a very good point. What would be your top priority for flexibility? Because we're all interested in that.
Right. I think it would be to allow critical access hospitals to merge into a different model, which would limit their need to have inpatient beds and to be able to be emergency departments and do outpatient care and keep the financials healthy in that model.
Good. Ms. Thompson.
Top priority would be recognition of the difficulty in acquiring and retaining providers to rural communities.
So if you could wave your wand, what would we pursue? Because that's enormously important. What would we do by way of provider policy?
Rural healthcare and rural communities create an environment that is unique in this country. The community cares for each other, and I think the opportunities that are before us that have been demonstrated in some of our ACO models create not only an integration of hospitals and physicians, but in all components of healthcare across the continuum. This kind of an environment is motivating, it is inspiring, and I think, quite frankly, could create a platform for transforming healthcare for the country.
Let's do this because I want to give Ms. Murphy the chance to wrap up this round. I'd like to, and the chairman's always very gracious about this, let's keep the record open for you all to give us as many concrete ideas for getting more providers to rural America, because this is enormously important. And we've tried loans, and we've tried this and that. And look, we all understand that year after year, we're faced with this question of whether there's going to be anybody to keep the lights on. In other words, you've got buildings and the like, but you got to have people who can run them. Ms. Murphy, your one priority for Medicare as we kind of use this period where we've got 5 years to kind of really push hard for longer term.
Expand the test for global budgets to different states.
Very good. Chairman, thank you. Only 7 seconds over.
Okay, Senator Roberts.
Thank you, Mr. Chairman. I'm very grateful that we're holding this hearing on rural health care in America. It's long overdue that Congress tries to focus on the unique needs as espoused by all the witnesses, people in rural areas, the healthcare challenges faced by these constituents. I have the privilege of serving as the co-chair of the Senate Rural Healthcare Caucus, along with the ever enthusiastic and helpful co-chairman, Senator Heidi Heitkamp of North Dakota. We have very similar problems or challenges. We don't have problems, we have challenges. And we've long said that rural residents deserve the same quality health care as their urban counterparts. I think every witness has gone over that. There's no reason why rural communities should be left behind as other areas continue to advance their health care systems. Dr. Mueller, thank you so much for reminding everybody that I was here in 1993, as you were, and it indicates that this has really been a long-term battle. I can remember clear back when it was not H2S, it was HEW, Secretary Joe Califano. I think you remember the time that all of a sudden there was a reg that came out that said that before any rural hospital could receive a Medicare reimbursement, 3 doctors had to review all of the patients that came in and the procedures and a team of 3 doctors had to do this every 24 hours. That was ludicrous. I don't know who came up with that. But then I decided it would be a good thing to be for that, because maybe one of the doctors would stay if, in fact, they were inspecting the hospital. But it's been a long-term effort. I want to focus, by the way, we have 86 critical access hospitals in Kansas, and I hope that when we renovate, I think Ms. Thompson said we should renovate, we should not eliminate. We're on first base or second base, trying to hold on. I don't want to get picked off by all of a sudden saying no to the critical access or moving to some other thing without really knowing where we're going. I want to really concentrate on the workforce situation, and I'd like you all to comment on that. Recruiting, training, and retaining staff is one of the biggest challenges we have. Example, in some areas, our physician assistants or nurse practitioners may be the only primary care provider available. We have to drive quite a few miles to get to that hospital, like you have in Alamosa, Ms. Martin. In Wyoming, they have to travel a couple of 100 miles maybe to do that. So let's go down the panel and say the one thing that I'm really interested in is the federal regs that come in between the provider and the patient. I'm talking about the 96-hour rule. I'm talking about the face-to-face regulations, things that just don't, it just takes a terrible amount of time and expense. And if you could really focus on that, what suggestion could you make? And we'll start with Dr. Payne.
Senator, I would defer that question to my colleagues who have much more expertise on that than I do. If that would be all right.
That would be fine, Dr. Mueller.
2 suggestions. One is looking at Medicare conditions of participation and what's required for supervision, the kind of thing you alluded to from the Califano years still exists today. And second, whatever we can do to open up even more the use of telehealth services to support the local rural healthcare professionals. And we've got some of that, as I mentioned earlier, in the Chronic Care Act to work with.
You mentioned telemedicine. I'm not trying to interrupt Ms. Martin, but there were 3 unique places where telemedicine was to start out. This is back in the 80s. One was in New Mexico with an Indian reservation, another was an island in Maine, and then the third one was Cimarron, Kansas, in between Garden City and Dodge. And they were selected. And we were about to announce that, and then all of a sudden they called up and said, don't announce that, we found a doctor. After all that hard work, I was very upset that they had found a doctor. And sure enough, the doctor came, and they were not like your doctors, the 2 that came back. 6 months, that doctor was gone. And in the meantime, we lost the opportunity for the telemedicine. Now we have it back, but then it's just, very typical. Now, you've got 2 doctors that came back because they believed in their community and they wanted to live in a community where they could raise their family and all the good things that's been referred to by Ms. Thompson. But on the federal reg side, which one would you pick?
I think I would pick the aligning quality measures so that as we measure value in rural communities, they're with measures that are relevant to who we are and what we provide. Right now, we report so many different measures to so many different agencies, and they're not meaningful always in moving us ahead with our quality. For instance, some of the things we report on, the volume that we do is so small that one single fallout appears to make us look like we have a lesser quality than maybe our urban counterparts, and that's just simply not true. So I think that is a very important point. And then the point with meaningful use, the evolution of meaningful use has certainly improved the use of technology in the healthcare industry, but the pace at which the change is happening and the expense that it takes rural facilities to keep up, I worry about those kind of measures really getting between the doctors and their patients.
Ms. Thompson.
Yeah, consistent with my concerns around access for providers, I would strongly recommend continuing to expand the use of telemedicine.
Dr. Murphy.
I think the 2 I would give. I think the relaxation of Medicare regulations in terms of allowing rural hospitals to maybe execute more innovative strategies in recruiting physicians. So we have some rules that prohibit that. And secondly, I think the relaxation or the acceleration of the ability of the Medicare program to waive certain requirements for rural hospitals on their overall management. And CMI,
I thank you all for your
CMI
testimony. Senator Enzi.
Thank you, and I appreciate that this hearing is being held, and I appreciate the great talent that we put together to do it.
Didn't see.
I'll yield.
No, that's Senator Cantwell. You were next. Senator Enzi said he would yield, but
Mr. Chairman,
yes.
if I could, I think in order of who is here, it would be Senator Enzi next, then Senator Cassidy, and then Senator Cantwell of the senators who are here.
I appreciate that. Senator Enzi, why don't you proceed?
Thank you. Thank you. Again, I appreciate the talent and the fact that we're having this. I come from the least populated state in the nation. Our biggest city is 60,000, and all of our towns are at least 40 miles apart. We only have 19 towns where the population exceeds the elevation. I have one county that's the size of Delaware, and the city, and you get to be a first-class city when you hit 2,500 people, and they just did, is 2,500 for the whole county. So we just try to keep a hospital open there, which usually means having a physician's assistant. So this is a critical hearing for us, and I'll begin my question with Ms. Thompson. The way Medicare pays rural hospitals, including critical access and Soul Community, like we have in Wyoming, it's closely related to inpatient services. As medical providers have started to shift towards providing more and more services on an outpatient basis, is the inpatient metric still the most appropriate measure for hospital costs?
I think that's a great point. I'm not certain that it is. When we began our work in the Pioneer ACO, the entire question around utilization of inpatient services was very much at hand, because that's very much what drives the predominance of spend and what calculated the PMPM. And in the contract with the federal government in the ACO, we essentially made a promise that we were going to reduce that total cost of care while improving quality to the Medicare beneficiaries. As a result of a lot of focused work and investment in reducing spend, we reduced inpatient utilization, and a lot of these services moved to outpatient. And what I think is more important in terms of the takeaway for this hearing is not that we reduced the spend or that we improved the quality, both quite important and both predominant components of the agreement in terms of the ACO. What we learned, and what I believe is so important as we rethink policy around rural health care, is how strong and how absolutely woven together a rural community is in commitment to caring for its patients. And in that lies some secret sauce in terms of how we rethink not just payment for hospitals or how we think about inpatient or payment for physicians or payment for home care, which is typically how we think about policy development, but rather how do we look at an organized system of care of a defined community, whether it's a rural hospital with 6 counties they're serving, and create an accountability and motivate a community to want to come together, whether in a global payment model or in some model that gets us out of this siloed way of thinking about how we organize payment structure in rural America. And in that way of thinking, I believe we will transform not only how we pay for care, but how care is delivered and how we recreate an entirely new healthcare system. That, to me, was the most important thing.
I'm running out of time.
I'm sorry.
Thank you very much. For Dr. Murphy, Medicare used to allow states to decide whether to designate hospitals as critical access I understand we prohibited state-based designations because of concerns they were overutilized, but allowed hospitals that had already earned that state-based designation to keep it. In cases where the critical access designation may have been overutilized, how do hospitals compare to the CMS definition of a critical access hospital?
So I think the definition of critical access hospital senators have, and their impact on whether a hospital is a CA or a non-CA is probably outdated to even think about it, because the problem suffered by rural hospitals today is really because the healthcare industry has changed. And critical access hospitals receiving, whether they're designated or not, they still have all rural hospitals have the same problem. They have little resources to deliver any type of a substantial inpatient care. They're devoting all their resources to inpatient care for a very small number of patients. So whether the critical access hospital designation was definitely a plus for hospitals 2 decades ago. But I think what we're faced with today is any type of assistance to hospitals that exist in the fee-for-service environment, whether it's tied, regardless of where it's tied, is going to lead us to the same place sitting here 2 years from now if we don't take a look at an innovative payment model.
Thank you. And I have some more questions, but if we have a second round, I'll do those. Otherwise, I'll submit them. I appreciate all the expertise that we have here. My time's expired.
Senator Cantwell.
Oh, excuse me, isn't Cassidy next? Yeah.
Colleagues, I know it's been hard to follow. I believe in order of appearance, Senator Cassidy is next, and then Senator Cantwell, and hopefully we can get both of these colleagues in the next few minutes.
Ron, what would I do without you?
As the Jewish people would say, oi.
Senator Cassidy, I'm sorry that
All right.
No problem.
I never overlook you, sir.
As my daughter would say, OMG. So anyway, thank you very much. Folks, I'm a physician, and I worked in a hospital for the uninsured, and often interface with my colleagues who are in an emergency room at some understaffed critical access hospital, but so understaffed that they frankly had to send all their patients to the hospital where I worked. And so a lot of what I will say now will reflect that perspective. Let me first go here. I'm interested in the Medicare wage index, in which hospitals with a higher cost structure get more. If you will, the more get more. Now, it seems as if under current law, you're based upon your geographic area. Rural hospitals in my state cannot compete with the urban hospital because of Medicare policy, which tells the urban hospital, we're going to give you more. And so, obviously, if you're a nurse and you have to decide where to work, you tend to go where you would earn more. The cost of wages, current policy does not have a floor or ceiling in place for an adjustment in which the cost of wages is considered when reimbursing providers. And so, as I just said, urban hospitals get more, rural less. I guess I could ask many of you this question, but Dr. Pink, does the lack of a ceiling or floor for the Medicare wage index, frankly, give a perverse incentive for the urban hospitals to keep increasing wages, to make it harder for a rural hospital in Louisiana or Iowa or Tennessee to compete and to be able to keep that nurse who lives close to home?
Senator, we have done some research on the various rural designations that Congress has created, and there are some of these designations where the wage index does play a key role. For example, one study we completed last year, we found that many of the sole community hospitals in the country, it's an important payment designation, but they are located in states which have lower wages, and therefore the hospitals that are eligible for that designation, in fact, there's no advantage to taking it. They take the PPS payment instead of the sole community. So I believe that it is an issue. We have not studied it beyond sole community hospitals, however.
Okay, I will say that Senator Isaacson has a bill of which I co-sponsor to put a floor under the Medicare wage index, which we do think would help rural hospitals substantially. Secondly, and I'll stay with you, Dr. Pink, over the last decade, there's been a lot of consolidation in hospital systems. Just for folks to see, Obamacare passed in about '09. That's kind of an inflection point. Whether or not it's causal or just associated, we don't know, but why don't you show others to see as well. But subsequent to '09, we can see that the number of consolidation episodes has increased, about doubling year to year. Now, we know that increases cost. There's good data showing that prices at a monopoly hospital 12% higher than those markets with 4 or more rivals. And I could give more evidence to that. Dr. Pink, given that these mergers coincided with rural hospital closures, I don't know the answer to this, I'm asking you, has consolidation by large hospital systems reduced competition or increased prices and kind of resulted in rural hospital closures?
We have not studied urban mergers and acquisitions, Senator. I can say that for many rural hospitals and small communities, merging with a larger health system has been the only option available to them, where they are literally faced with the choice of, do we have nothing, or do we affiliate, or are we bought by a large system?
Now, Ms. Thompson raised the issue of these ACOs not being extended to the rural area, but presumably if an urban hospital consolidated bought a rural hospital, they would just extend their ACO out to the rural. Ms. Thompson, has that not occurred?
That has not occurred.
Now, pourquoi pas, as my French teacher would tell me to say? How come not?
The cost-based reimbursement model that is at place with critical access hospitals simply reduces any opportunity because they're reimbursed based upon their costs associated with the Medicare patients they're caring for.
Okay.
So they don't have an opportunity to see the shared savings associated.
So we get the consolidation, which may keep the doors open, but none of the extensions, the putative benefits extended to others. Let me move on. I got 9 seconds left, and I'll fit one more in. Ms. Martin, we've heard about the rise of freestanding ERs in places like Texas and Colorado. Several of you have mentioned that when these facilities close, frankly, folks' primary complaint is, I want to have an emergency room nearby. Proponents argue the facilities are providing increased access to ER care in rural areas where not financially feasible to have an entire acute care hospitals. The opponents argue that they're cherry picking, and although I'm told they take anybody who comes, and that the physician-owned facility, the fact that physicians owned it, is an issue. Currently, the facilities are not reimbursed by Medicare or Medicaid patients. Ms. Martin, you work in Colorado. They're allowed. If we're to allow these facilities to be reimbursed by Medicare and Medicaid, would this be a good thing for your rural area, increasing access to rural ER care, if you will, or not?
I don't believe that it would be a good thing in rural areas. The freestanding EDs that have originated in Colorado are all exclusively in the urban areas. They're not in the rural markets. And I believe in a rural market, the idea of an emergency department conversion from a critical access hospital is that you keep care located close to a community where...
Now, let me stop you for a second. It's impractical if somebody has a head injury. You're not going to have a neurosurgeon in a rural hospital, and quite likely not have a general surgeon. Just because the general surgeon cannot, my wife's a general surgeon, I'll use the feminine, she cannot maintain her practice because there's not enough volume and or your payer mix is so poor. So I thought the emerging paradigm is if you stabilize the patient, do as much as you can, but then transport quickly. Would that not work in Colorado?
I guess what I'm referring to is the freestanding emergency departments that have been created in the Front Range market. In our rural community and the hospital that I work in, we do have general surgery, and some of the critical access hospitals that neighbor us, they do a lot of stabilization and transferring. That's what we do in the rural facilities. I think that keeping an emergency department in a rural facility is very positive and something that we need to do collectively. My statement was simply that the freestanding emergency departments that have started on the Front Range have not...
You got to wrap it up because I'm way over. Okay, I'm sorry, I didn't mean to interrupt, but I'm 2.5 minutes over. My staff and my folks have been forbearing. I apologize. Thank you very much for your answer. Thank you all.
Not to beat a parliamentary horse to death, but Senator Campbell, if you would like to be a member of the always powerful Senate Agriculture Committee, we recognize people on a bipartisan basis going back and forth as opposed to the TOR schedule espoused by my distinguished friend from Oregon, the time of arrival. So for the third time, I am delighted to recognize you.
Justice for Senator Campbell.
Thank you, Mr. Chairman, and I would love to be at this moment ex officio to the Ag Committee, and I so appreciate your leadership and all that you're doing to express that we need trade and not tariffs.
Without objection,
Thank
your
you.
comments are
Thank
in order.
you. I thank the witnesses and thank both my colleagues for this important hearing. Obviously, I wasn't here, Ms. Martin, when you gave your statement, but this statement by you about where you should live should not determine whether if you live resonates in lots of my state. The access to healthcare through the Medicaid expansion was big in rural communities in my state. Writ large, 600,000 people in our state got expanded coverage. But we have counties like Douglas and Chelan where, so the chairman knows where our apple and cherry and pear industry is located. They have seen an uninsured rate drop more than 60% thanks to that Medicaid expansion. So I just wanted to ask about the importance of making sure that we keep that expansion and making the importance of not letting any kind of cap or reduction. Under this discussion that we had, CBO was saying that the previous proposals on block granting and changing Medicaid might cut as much as a quarter out of Medicaid over the next 2 decades. So is that problematic, Ms. Martin, for rural?
I think certainly the ACA expansion made a very positive difference in the community where my service area is, and I think in Colorado overall, we had a uninsured rate of nearly 20%, and that has been reduced in my community down to low single digits. And so the coverage for patients allows patients to get access to care. It's improved the financial bottom line of certainly our organization. I spoke earlier that 70% of our population is Medicare and Medicaid, so our relationship with government payers is critical to our survival.
Did you say 70?
70.
And ours is up there as well, over 50. I don't know what the latest numbers are, but yet I don't think people quite understand that that's the challenge we face. I mean, we love our rural economy and we love our rural communities. They're a great place for people who are aging to retire and live, and it's more affordable, but that means it's a different mix of the population as it relates to how you build a healthcare delivery system. So the Medicaid expansion is so critical to that. I also wanted to ask about telemedicine because that is another delivery system that I think for us, we have this Project ECHO, the University of Washington, working with Harvard. You've heard of it, obviously, probably in your state as well. But it's allowed medical professionals from Seattle to consult with people over in the Yakima Basin, some of our clinics, to talk about the decisions for really highly complex patients on for hepatitis C and substance use disorders. So how do we, what do we do about that as it relates to the payment system? Because I don't think fee-for-service is any kind of friend to that cost-saving technology and that cost-saving collaboration that's existing.
I think in our community, we're modestly beginning the use of telehealth, and part of our challenge is that we don't have the resources for a lot of the startup equipment, and some of the payment constraints don't allow us to be able to provide the service. I think one of the best things we could do is to invest in the startup expense for particularly for rural hospitals, and then allow the services to be reimbursed on a fair basis. We currently do telehealth now in our community for infectious disease, genetic counseling, and we're trying to build that for oncology coverage and for cardiology coverage, and it would actually save the system money. For instance, when a person goes into our emergency department and we have one cardiologist in the community, when that person's not there, we have to, if the condition of the patient's warrants, we have to transfer them to another area to be evaluated by a cardiologist. They oftentimes get transferred, are evaluated, and then they're dismissed from the hospital. If we could have cardiology services available 24/7, we would save the expense of an air ambulance or a ground transport for a patient with a cardiology problem.
Well, and there's no reason you can't with telemedicine, right? With that kind of technology.
Yes, ma'am, that's true.
So it's just getting this, getting it recognized into the system in some way.
And paid for.
Right. Well, that's what I meant. Recognized into the system. And that's why the challenge that just a fee-for-service model challenge. For anybody, well, actually, I don't have any time left, but the doctor shortage issue for rural communities continues, and we just need to fight that. And so, we have counties in our state that have very, like 4,000 people and no access. So we've got to do better. Thank you.
Senator Carper. Thanks so much. My first question for the witnesses: how many counties are there in America? All right, let the record show they have no idea. The answer is 3,007. Delaware has 3 counties. The southernmost county is called Sussex County. It's the 3rd largest county in America. We don't have many of them, but we make them big. Sussex County, we raise more chickens than any county in America. Last time I checked, we raise more soybean than any county in America. I think we raise more lima beans than any county in America. We have more 5-star beaches, I think, than any county in America. All in one county, Sussex County. And we have a lot of rural areas and a lot of people who live in rural areas despite all of that. We have a lot of people who live along the coast, Rehoboth and Lewis and places like that, Dewey Beach. But the rest of the county is largely agriculture. And we have some hospitals, they're rural hospitals. We have community-based outpatient clinics. We have a VA clinic that's actually quite good. But we still have a lot of people who don't have access to health care because they're just so spread out in a big county. I want to talk a little bit with all of you now that we've gotten out of the way. I want to talk with you about costs that flow from tobacco use, costing our healthcare system. It's actually really costing all of us. And I understand that we're spending in this country today about an extra, I would say, $200 billion each year because of our addiction to tobacco products. And we're spending, I'm told, another $150 to maybe $200 billion a year because of obesity from one end of the country to the other, including in Sussex County. But I'm told that America's rural communities are still more likely to use tobacco products than other parts of our country. Our rural communities are also more overweight and more obese. I would just ask what tools. Here's my second question of the day. What tools, what resources, what delivery system reforms could we be using to reduce the disparity in rural communities when it comes to tobacco use and obesity? And I want to start with Dr. Murphy.
Thank you, Senator.
So I was told you're really good on this question.
Oh, thank you. What we talked about earlier was a new way to pay for rural health. I don't even say rural hospitals, but a new way to reimburse rural hospitals. And it is a multi-payer global budget system that allows hospitals to focus on the problems that you just talked about and instead of investing in subscale services, invest in tobacco cessation programs, invest in substance use disorder treatments, invest in the clinical or the health status outcomes that we're looking for, and to end this disparity or to gradually decrease this disparity between rural health outcomes and those of their urban counterparts. So that is the beauty of this model. It allows for the investment in care coordination. It allows communities to really take those chronic disease problems and allocate the dollars that they were receiving from subclinical care services that they had to provide because that's the only way they got paid. It now allows them to address this population health more.
Let me ask the other four witnesses. If any of you agree with what she has just said, would you raise your right hand? All right. If any of you have something you'd like to add to what Dr. Murphy said, Ms. Martin.
I would just like to add that an investment in primary care providers, because I think that is the relationship that impacts patients' behaviors and impacts patients' ongoing quality of life. And so in so many communities, it's the importance of the primary care provider that impacts these behaviors.
Anybody else want to add to it? Yes, please.
I would add investment.
And how do you pronounce your name?
Keith Mueller.
Mueller. Right.
Yes.
The right way.
Yes. I would add to that the investment in public health infrastructure, and you can come at that in two ways. One, encouraging collaboration between the healthcare, the clinical sector, and the public health sector, which the ACO model does. And two, direct investment into public health agencies.
All right. One last quick question. What are your recommendations for how we can increase the supply of mental health workers and improve access to mental health treatment in rural and underserved areas? And we start all the way on my left, please. Would it be Dr. Pink?
Yes, sir.
Please.
Again, I would defer to my colleagues. I have not got expertise in that area.
All right, thank you.
One comment would be to integrate our support for behavioral and mental health services with primary care.
Okay, thank you. Ms. Martin?
I think it's investing in the education in programs where as community hospitals, we can educate and train a workforce of our own. We have an extreme shortage in the number of qualified professionals in that area.
Good, thank you. Ms. Thompson?
Yes, I believe it's to further study the integrated health home model that is at play with our Medicaid population. And I think there's a great deal to learn there and a great deal of excitement to create in young folks that we can get into high schools and educate and motivate them about the opportunities in mental health.
Okay. Dr. Murphy, do you want to add anything to this?
I would just say leveraging the technology so that we can access, rural areas can access the more urban centers.
All right. Where have y'all come from? Tell me where you're from. Dr. Murphy, where are you from?
I'm the Chief Innovation Officer at Geisner.
Oh, good. Yeah, I've been there before. Guys do good work.
Yeah. Unity Point Health in Des Moines, Iowa.
Okay, yeah.
San Luis Valley Health, Alamosa, Colorado.
University of Iowa.
University of North Carolina, Chapel Hill.
Okay. Well, some of you come from a long way, so we thank you. And we thank you for the work you do. It's really important for our country, for the people of our country. Thank you so much.
Senator Portman.
Thank you, Chairman Roberts, and thanks to the panel. I was here earlier to hear your testimony. I really appreciated some of the insights about the special challenges we face in the rural areas. I come from Ohio. We have a lot of big urban hospitals, and we have a lot of small rural hospitals. Sadly, some of them are closing down or consolidating. And I would tell you, in my state, one of the issues that is particularly difficult to deal with in our rural areas is the opioid epidemic. And I would think if you did a per capita analysis of the opioid epidemic in my state, you would probably find that in the rural areas the problem is even more acute than it is in some of our suburban and urban areas, although it's in every zip code. But the difference is really not so much the per capita impact, but the services that are provided. And one of the issues, as you know, is that we have more and more children who are being born with neonatal abstinence syndrome, meaning they really have to be taken through withdrawal themselves. We've got some great programs taking moms who are addicted, weaning them off of their addiction, and helping to ensure these babies are born without the neonatal abstinence syndrome. But it's overwhelming us, our neonatal units. I'm sure the same is true with you. One of the things I'm hearing about from our children's hospitals is that sometimes they can take care of the babies shortly after their birth, but then these babies go home and there's not the ability to continue to monitor, particularly in our rural areas. And so I guess what I'm asking you today is, and this, I know Dr. Murphy, you mentioned the opioid epidemic. I've heard earlier, I think you were the one who talked about that. But to the hospital CEOs, maybe you could help me a little on this. What services do your hospitals offer to support the longer term recovery needs of these growing number of children who have this neonatal abstinence syndrome, and for their moms and their families. And in particular, if you work with kids with NAS, how do you work to ensure that the families receive the support that they need?
In our community, we've certainly seen an increase in this issue. Just last year, about 11% of the babies that we delivered had this syndrome that you speak of. And we've done a lot of training with our staff to have them have the skill set to help the babies, for the first few weeks of life. And we sometimes keep them for that period of time. When they move out into the homes, and oftentimes, unfortunately, they're going into foster homes because if the mother was a user, unfortunately, they are placed with in foster families. And so we have pediatricians who try to work with these families and develop it. And we have like a grassroots community organization that involves the schools, early childhood development, some of our primary care providers. And together we're trying to sort of leverage and learn resources. It's a challenge because there's just not a lot of information about that. We hear from our school teachers, particularly of elementary schools, that they don't feel equipped to deal with the challenges that some of these young children bring to the classroom. And so I think just additional resources around education and training so that our workforce would know better how to help these children would make a huge difference.
Yeah. Any others?
Senator Geisinger, we're just beginning to develop a program for moms who have substance abuse and then their children subsequently born with neonatal abstinence syndrome. So the vision for the program is that we would intervene when the mother begins medication-assisted treatment prenatally. And then we would, what we say is wrap our arms around the mother and the baby with services such as behavioral health services, addiction medicine, counseling, pediatric services, and other social services that would enhance the likelihood of the mom staying in recovery after the baby is born. So the idea behind it is that we would offer these services for a period of up to 2 years and determine evaluate the model and determine what interventions really help that mom stay in recovery and go on to live a productive life.
Well, thank you. And we did pass legislation here called the Comprehensive Addiction Recovery Act, which has a separate title for pregnant moms, postpartum moms, and these kids with NAS. Since that time, we passed a budget which increased the funding for that. So for those of you who aren't aware of that, apply for it. We're looking for good pilot programs around the country. But I think Ms. Martin's right, Dr. Murphy's right. This is, if we can spend some money up front to avoid some of the longer term problems and figure out what works. You mentioned information and the right kind of therapies to be able to help these babies as well as their moms take advantage of this moment. Many of these moms are facing their addiction because of their pregnancy. In other words, they don't want their kids to be born with this syndrome, so they're willing to go into treatment that maybe previously they were not. And I think Dr. Murphy is right. How do you then, once the baby is born, to keep them? Usually, it's a Suboxone treatment. It's a weaning off of the opioid. How do you then keep them into that treatment program and longer-term recovery and use that family relationship to help kindle some better prospects for longer-term recovery? So anyway, we look forward to working with you all on that. And I think in the rural hospitals, again, the rural setting, we have a particular challenge. And I appreciate you being here today and look forward to following up. I have another question on the Stark Law, but I will offer that as a question for the record. Senator Bennett and I have some legislation I want to get your views on. Thank you.
Well, thank you, Senator. Coop, you're up next.
Thank you, Mr. Chairman. Must be high noon. So thank you for holding this hearing. We have in my home state of South Dakota lots of challenges in accessing healthcare services in rural areas, and we have providers who work diligently coming up with creative solutions, but there are still barriers and complications that they face on a daily basis. Part of it has to do with traveling long distance and having limited transportation options. There are big hurdles for people to overcome, and attracting providers, of course, to rural areas is another challenge that we face. Too often we lose South Dakotans if they attend school and train in other states. And we've got a unique issue in South Dakota as well with our tribal communities, making sure that they have access to quality health care services due to the pervasive problems that Indian Health Service facilities throughout the Great Plains region continue to have. So I look forward to working with my colleagues on this committee and trying to advance solutions that will address many of these challenges. Dr. Mueller, in your written testimony, you mentioned that Rupri Center has completed multiple studies on how telehealth can serve as a tool to expand access to care in rural settings, and I couldn't agree more. I understand that you have a current project that's looking at Avera Health's e-care initiatives in South Dakota, which range from emergency department, e-ICU, e-pharmacy, e-behavioral health, and more. I've seen some of this technology firsthand and know they're working hard to innovate. From, I should say, for this committee's benefit, could you discuss what you've learned so far about Avera's model and how it's helped increase access in our state of South Dakota?
Well, thank you, Senator Toon, for the question. I'll focus primarily on what we've learned about the use of telehealth in the emergency rooms, because that has impressed us the most. What that has done, especially since I mentioned earlier CMS conditions of participation, a condition of participation was changed a number of years ago to allow meeting the necessity for an on-call physician through the use of telehealth. And that has made a tremendous difference across South Dakota and other facilities that Avera supports, because you can have an advanced practice primary care provider, not a physician, in the ER that can quickly access a board-certified physician. But more important even than that is the finding that the use of that kind of telehealth actually helps in recruitment and retention of primary care providers. And this goes to a broader point that the more we can do to support the professional activity of those healthcare professionals in the local environment, the greater the likelihood they'll come there, because that's how they want to practice, with the support of board-certified physicians, and the greater likelihood they'll stay because they're getting that kind of consultative support. The other quick example is in the case of pharmaceutical services inside the hospital in particular, which is how the eHealth suite from Avera reaches out. You can meet the requirements for review of medication as it's being prescribed in the hospital much more efficiently and effectively through the use of telehealth.
We've perhaps, as you know, put forward multiple policies that were signed into law this year that will reduce barriers to the use of technology in Medicare and promote telehealth and Medicare Advantage and accountable care organizations and other areas, including in treating stroke patients. And these are significant advancements, but I'm wondering if there are other areas where technology can transform delivery of care in rural states. I mean, what should we be looking for in terms of technology opportunities in Medicare and Medicaid from your perspective? And if, Ms. Thompson, if you would care to comment on that as well. But we're making some headway. What else should we be doing?
I think we should try to learn as rapidly as we can from, you mentioned the use of telehealth in ACOs and Medicare Advantage plans, so that we can transfer that knowledge into the basic Medicare system and affect reimbursement policy, as was mentioned earlier this morning, as one of the barriers to the expansion of telehealth.
Ms. Thompson.
And I would simply add, I think there's a great opportunity to attract the new generation of physician providers, or providers in general, to rural health. These young people have grown up with technology. It's very familiar to them. And frankly, it gives them a lifestyle that is something that is very attractive, and I think would help us answer the needs of recruiting to the rural areas.
Okay. Mr. Chairman, I have another question I can submit for the record having to do with EHRs and how that impacts service delivery in rural areas as well. But I can, so my time has expired, so I'll submit that for the record. Thank you.
We thank you, Senator. Senator, for one, suddenly we have four more. Just magically appeared here. Senator Warner.
Thank you, Senator Roberts. One of the issues that, and I think Ms. Martin was raised in your testimony, but I'm increasingly seeing kind of isolated areas where there may be two competing hospital systems, and they leave an isolated island in between where the two systems catchment area comes, and you may have rural communities with a single doc, and in my state, the county of King George, where the doc's been practicing 35 years, done a great job, is about to leave. And because it falls in between two competing healthcare systems, nobody's wanted to take this region. And should he retire, and frankly his system is being sold, we have a community that could frankly go without any kind of coverage at all. This problem of isolated areas where there's not a larger system that provide the back office coverage, even if the rural area has relatively high affluence, this one particular community, King George, has relatively high affluence. How are we going to get at that? How do we? Is there any systemic things we can do, whether it be a slight increase in terms of Medicaid reimbursements or other reimbursements to make these islands more attractive on a longer term basis?
I think I don't experience that quite as much in my region of Colorado because geographically we're defined by a mountain range, and so certainly anything within our valley we're covering and taking care of. We see that a little more in the eastern plains of Colorado, where you'll have a community that with the retirement of a physician or the closure of a hospital, you have a gap in coverage. And I really hope that the statewide leadership can make a difference in that and pushing people there. I do think that for the age of physicians going and starting practices on their own, if it hasn't came to an end, it's slowly coming to an end. And I think it's going to be working with existing rural healthcare systems so that they have the financial means to do a startup and a practice. I think loan repayment for physicians makes a difference with that, and I think certainly Medicaid reimbursement makes a difference with that in rural communities, because when you have 70% Medicare or Medicaid like you do in my community, you can't make a private model business work.
Right, this notion of an individual doc going has to have some kind of back office operation to support him or her. And do you have other ideas? I know back in the 90s, Robert Wood Johnson's foundation had a huge kind of focus on this issue of that underserved communities and GP practices opening up. But as you said, the ability to open up a practice on your own right now without some additional support from a overall system is really hard. Is there any way, has anyone thought about beyond what the government could do in terms of reimbursement levels or loan forgiveness, incentives to healthcare systems to make sure you don't leave these isolated islands not having coverage?
I guess my thought on that would be that I think rural systems do really look at that geography and make a difference. The idea of even the J-1 visa programs, things that will help small hospitals like ourselves be able to get providers that will go to these communities through long-term incentives come back. And that's what comes to mind for me. I think the idea of a critical access hospital or a rural hospital like the one we have in Alamosa, being able to get paid under a different reimbursement model in those communities gives you the resources to take on those communities that don't have providers. I think it's a real challenge, and I wish I had a better answer.
Yeah. Anybody else want to add on this? I do think the notion of a higher reimbursement level, but then do you create almost an incentive for some systems to kind of drop providers so that they could then qualify for an increased reimbursement? It's a real conundrum, and I'd be happy to hear from anybody else on the panel. This will be my only question. Well, I think this is not, when you had the hospital systems who want to make a profit and they are not willing to stretch for these isolated islands, and with the retirement of many docs and the inability for a new doc to go into these communities, real problem, real issue, can't set it up on their own. We've got to find a way to crack this code. Thank you, Mr. Chairman.
Senator Cardin.
Thank you, Mr. Chairman. I thank the panel. I first want to just concur in comments of several of my colleagues on telemedicine, and particularly for rural health care. I think it's really an area that we can do much better. I'm proud to join some of my colleagues in legislation that would allow for Medicare reimbursements for telemedicine broader than it is today. But I want to talk about what we do in Maryland We are the only state in the country that has an all-payer rate structure for hospital reimbursement. And we went to the next plateau a couple years ago and just approved this month the final aspects of this demonstration that allows our hospitals basically to be judged on the overall reduction of the growth rate of healthcare costs rather than just the hospital element of it. So we have an all-payer rate structure in our hospitals, but coordinated with reducing the overall cost of that patient's healthcare beyond the hospital care. So there's incentives to keep people healthy. And by way of example, the Western Maryland Regional Medical Center, which is in a rural part of our state, offers care coordinators, navigators, and local practices, uses telemonitoring for blood glucose, blood pressure, and weight, works on the social needs of the patients, and that can be incorporated into the all-payer rate structure, which means all of the third-party payers are helping to reimburse for that because you can't get discounts in Maryland hospitals. So it works to allow rural areas to have full access to the continuum of services. So my point is this model, and this is now being implemented in our state, how do we take this type of a model in the rest of the country that is still in the stovepipe type reimbursements that to me work against rural America? How do we take the model of what we're doing in Maryland and use this to develop more access to care and reducing the growth rate of healthcare costs in rural America?
Senator, thank you for that question. So I had the opportunity when I worked at CMMI to work on the Maryland model and can share your enthusiasm with the model. And in Pennsylvania, there's actually a Pennsylvania Health Rural Initiative that is looking to do exactly what you just articulated. So taking the Maryland model in a state that is not an all-payer rate-setting state and develop a different methodology, but similar in the way that it includes all payers and has also the metrics of total cost of care involved in the model, but really using it as a way Maryland did for the TPR hospitals back in 2010, and trying to, but with 8 more years of knowledge on how do we transform and how do we focus on population health. So we concur that it's a great model. I had previously testified that in your state next week, the Johns Hopkins University School of Public Health is conducting a summit for states to attend on global budgeting. And it's my understanding that we have over 26 states that are interested in pursuing this.
Yes.
I would just say that in Colorado, we're beginning to explore this model as well. We're very much in the beginning stages of it, but the conversations around global budgets and ways to keep our community healthy and control costs is at the forefront of our mind too.
And I just simply want to applaud the recognition that the current payment structures, the current payment systems for rural America, while all well-intentioned and all designed at a certain point in time to help save rural healthcare, at this point in time are now setting rural healthcare back and not being able to move into population health and the alternative payment models and MACRA. And I just want to applaud the work.
Thank you. My concern is that I think the payment structure does not allow for this to occur, so you really have to find very creative ways in order to do it. And we should be looking at some mechanisms that allow you to use a reimbursement structure modification that brings down the overall cost of healthcare in your community so that the hospitals are not the driving force for utilization, rather that they are part of the overall coordinated integrated care. Thank you, Mr. Chairman.
Senator McCaskill.
Thank you very much, Mr. Chairman. I want to thank the chairman and ranking member. They actually moved up the hearing this morning because we anticipated that a number of us would be in the NDAA markup. we did so well in the NDA yesterday. We finished it last night, so I still appreciated the consideration. I want to talk a little bit this morning. Well, first, I want to just say for the record, this is a crisis in our country, the costs of healthcare in rural communities, and we are doing nothing in the United States Congress to address it at this moment. We know the premiums on the exchanges are going up because of various things that have occurred, and I think I can get everybody to agree that when we have more uninsured and underinsured, we have more rural hospitals in stress, and insurance premiums go up for those of us who buy it. Correct? Correct? All 5 witnesses agree. So every time the uninsured number goes up, it costs everybody who's paying, including taxpayers and including everyone who buys insurance. So the idea of keeping the uninsured number down is all about saving money in the healthcare system and making everyone responsible for their own healthcare bills. So it's just ironic to me that we're going to go back to the bad old days where uninsured numbers are climbing, and we're doing nothing right now to address it. And there's a lot of bills out there that would help. So I'm hoping that the leader, McConnell, will see fit to allow some of the bipartisan bills that have been negotiated to the floor so we can actually provide some relief. My issue I want to talk about, there was a really good state audit done in my state by the auditor, Nicole Galloway, about a rural hospital. And what was discovered was there was a small rural hospital that transferred operational ownership through a lease agreement in November of 16. And all of a sudden, there was this giant increase in laboratory billings. And what happened is the vast majority of these billings were for lab activity for individuals who are not even patients of that hospital. Billings began immediately after the management agreement, despite the fact the hospital in Unionville, Missouri had not even begun processing tests. The hospital partners, which is the company that took over this small rural hospital, also placed on the hospital payroll 33 out-of-state phlebotomists to perform laboratory services throughout the country. It appears that hospital partners reduced Putnam to a shell organization for purposes of lab billing. This morning, I'm directing a letter to the Inspector General at HHS to investigate this. Evidently, this same group was involved in the Northern District of Georgia, sued on a pass-through billing scheme at Chestatee Regional Hospital. The Missouri audit findings note that a large private insurance company has identified up to $4.3 million in payments for fraudulent claims to Putnam in recent months. So my question to all of you that are researching rural hospitals and that are working in rural systems, is this a trend? Are these companies coming around and buying up these hospitals to front for shady billings on lab work? Have you seen this anywhere else? No, you have not. Okay, well, this letter is going to HHS today, and I think there's some, in all likelihood, I'm betting there's some criminal activity somewhere, and I think that maybe there should be some kind of cap on payments to labs outside of the state, particularly if the billings are coming from a rural hospital. I know you all have talked about the lack of doctors in rural communities. I had the University Hospital in Columbia, Missouri say they were taking in more rural patients than they should. Rural patients were bypassing their local hospitals and going to the University Hospital, mainly because that's where their doctors were. Can any of you address, maybe Ms. Martin, you can address the real problem, especially that we have with OBGYNs being able to be in rural areas, and any ideas you might have of how we can incentivize doctors to stay in these rural communities, go to these rural communities and stay in these rural communities?
I think the workforce issues are very much challenges in rural areas. I think we spoke today about the loan repayment programs, the Conrad 30 J1 visa programs. I think they're very important to rural communities, but I also think it's about easing some of the regulatory burden on physicians who work in small areas, because they just want to be physicians. They want to take care of patients, and when they can work to the top of their license and to the top of their skill, they're more satisfied in a rural community. And I think that we talked about telehealth a bit today, because when physicians know that they can be covered when they're off and they're out, or they don't feel the burden of a 24/7 responsibility, I think that's a more satisfying opportunity for them as well. We know with OB-GYNs, we're very fortunate in the community that I'm in that we have 3 OB-GYNs that work there, and we work a lot with nurse midwives to do first line coverage for call for regular deliveries, to give them a little bit of relief so that their call time and their quality of life balance is different maybe than what they would experience without those. And so it's the use and the complement of those advanced practice nurses that helps to keep the OBs in our community.
Thank you. Thank you. Thank you, Mr. Chairman.
Senator Brown.
Thank you, Mr. Chairman. My state of Ohio struggles with some of the highest rates of infant mortality and maternal mortality in the country. Shamefully, it's partly because we've underinvested in public health for decades. It's more complicated than that. Between 2008 and 2014, 400 women died from pregnancy-related causes in Ohio. In 2016, more than 1,000 babies died before their first birthday. These losses, these tragedies weren't felt equally across all communities. African American communities in our cities suffered disproportionately to the greatest extent. We also know that in terms of maternal infant mortality, places like Appalachia, Ohio, and other small towns, generally a little more affluent than Appalachia, dealt with this. This hearing is about rural hospitals and rural health care, so I will stick to that. I'm concerned, though, that not in a conspiracy sort of way, but this committee has done nothing on that I can see on infant mortality generally, when the problems are equally acute, maybe even more so in urban areas among low-income people of color especially. There is a national Republican effort, troubling, that governors are, as work requirements seem to be the new far right-wing rage in this country, work requirements for food stamp beneficiaries, even if they're getting treatment from opioids, and even if they're working, even if they're incapable of working, they're also now looking to do work requirements for Medicaid, and they're doing it in a way that will absolve more rural white communities, high unemployment, from these work requirements, but will have these work requirements in inner city black families increasingly, because they're really smart and they figured out how to do it legally, apparently, but immorally, if I could say that. But because this hearing's about rural health, I will stick to a question about that. A couple of questions. Ms. Murphy, if I could start with you, what do we do? What do we do? I mean, partly taking off on Senator McCaskill's question, what do we do to support rural communities and improving outcomes for moms and babies? Ms. Martin said something about that. I'd like to hear your thoughts, and particularly maintaining access to obstetric services.
I think we have to be realistic with maintaining obstetrical services in rural communities. I think Ms. Martin gave an example where there's adequate coverage, 3 physicians there that in case of an emergency could certainly cover for one another. It's a very high intensity, an OBGYN has a very high intensity schedule. So you really need the numbers that Ms. Martin talked about to be able to effectively and safely render obstetrical care. So I think in areas where they're fortunate enough to be able to have the physician services on site in a safe in a high quality manner, I think then we should do that. I think we should work through other providers such as nurse midwives, certified nurse practitioners, physician's assistant, to be able perhaps to offer some of the obstetrical care in the rural community when it's not possible to deliver there, so a mom doesn't have to drive 35 miles for their monthly appointment. But I think it is a very I think it is a very difficult service to staff in rural communities unless you have the kind of the number of physicians that Ms. Martin talked about.
Thank you. A few weeks ago, I hosted a conference with Abby Duggan in our office, and Radhika worked with us to host a conference for CEOs from Ohio's smaller hospitals. We have incredible, from the big children's hospitals we have to some of the best hospitals in the country in Ohio. But rural hospitals are not often part of the conversation, and they rarely come to Washington. And so we hosted a number of them. One of the questions that came up, of course, was the challenge faced when attracting and retaining a strong workforce. So I'm sorry I've been in another hearing today, but from Ms. Martin's comments and Dr. Murphy's comments, I appreciate that. I'd like to, before I yield back, Mr. Chairman, and I wanted to thank, too, Senator Wyden has been helpful in this Medicaid work requirement. Which is, I know we're working on some things together. I wanted to thank him, but I want to just close with this and just a comment, Senator Roberts. I want to thank Senators Grassley and Casey for their work on a bipartisan bill we introduced together, Senate Bill 109, that would allow pharmacists to bill Medicare for services they are trained to provide in underserved areas. I understand pharmacists are not perhaps the greatest need in every case, but they obviously are central to a lot of this too. They can work then with rural hospitals to help improve access to basic healthcare services like immunizations and chronic disease management in their communities. About a dozen members of this committee, if I could just name them, Thune, Scott, Roberts, Stabenow, Carton, Nelson, Bennett, Burenzi, and Cantwell, also co-sponsors of this legislation. And I'm hopeful that, I know the chairman's not here, I'm hopeful that Chairman Hatch and Ranking Member Wyden will commit to working with Senator Grassley and me in this bill and other creative initiatives to help all of you deal with the challenges you have in workforce. So thank you all so much. Thanks, Senator Roberts.
Senator Wyden.
Thank you very much. And before he leaves, I just want to tell Senator Brown I'm anxious to work with him on the agenda he's outlined because, as usual, he's going to bat for folks who don't have clout and don't have power, and I want to thank him for his comments. So we have been at it for almost 2.5 hours. You all have been terrific, but what I am struck by is I don't think we have mentioned over the course of 2.5 hours what is really the backbone of rural health care, literally from sea to shining sea, and that is rural health clinics. And I'm heading home. We have 83 of them in my home state. I know, Ms. Martin, you've got a significant number of them. Mr. Mueller, you've got expertise on this. In my home state, from Curry County to Enterprise, these rural clinics are literally the backbone of healthcare. And they're where seniors go, and people go for preventive screenings, primary care services, and everything that helps them to stay healthy and out of the hospital. So what I'd like to do, since we're getting ready to wrap up, is go right down the row again, since we got this little window here to try to look at what's important going forward. I don't think it gets much more important than these rural health clinics. So why don't we start with you, Mr. Mueller? Everybody, one item on their wish list for the rural health clinics going forward. Mr. Mueller.
Optimizing the use of the non-physician professionals through, and this is state policy, scope of practice, but federal policy on conditions of participation and supervision requirements.
I missed your colleague, Mr. Pink. Maybe I just need to wear my glasses, Mr. Pink.
The suggestion made by Dr. Mueller, I would strongly endorse.
Okay. Sorry.
The issue with co-location and co-mingling rules that prevent the true integration of the healthcare provider.
I think that's so important. Chairman Roberts is the co-chairs of this really important rural health caucus, along with our colleague, Senator Heitkamp, who talks to me about this constantly. Hardly a week goes by when she doesn't bring it up. I just say, Mr. Chairman, this whole question of the commingling rules that Ms. Martin is talking about, this just looks like a bureaucratic la-la land to me, trying to sort all this stuff out. So I'm going to talk with Chairman Roberts about it. Yes, ma'am.
Strengthening the support to these advanced registered nurse practitioners and PAs and extenders that many times are working in very isolated areas, to give them the support, the education, the retraining, and the access to consultation.
Giving them a bigger role. I got to tell you, we had it in our Healthy Americans Act, our bipartisan bill with 8 Democrats and 8 Republicans. You ought to be able to practice up to the top of your license. and particularly in these rural areas. So, Mr. Chairman, that's another one. I mean, why you wouldn't let people practice up to the top of their license in a rural area? I mean, that's just common sense. That has nothing to do with Democrats and Republicans. Yes, ma'am. What you're doing. Well, you all have been terrific. You know, we have been at it for close to 2.5 hours. And I think, you know, to me, you know, without rural health care, you cannot sustain rural life. This is not rocket science. There are a couple of pieces to the puzzle that are a part of this. We are trying, for example, to expand broadband. And one of the striking aspects about this is I think we started a revolution in Medicare with our chronic care bill, because what we're doing is moving from acute care, which back when I was director of the Gray Panthers was a program. You broke your ankle. That's not Medicare anymore. Today, Medicare is cancer, diabetes, heart disease, strokes, that kind of thing. So we had a terrific group of members led by Senator Schatz and Senator Wicker come and make the case for telemedicine. It's really, really important in rural areas, but what we've seen in Central Oregon and the like is if they don't have broadband, they can't tap all the opportunities for telemedicine. So there are a lot of pieces to this puzzle, but you've given us a lot of suggestions. I want also to say I'm especially looking forward to the suggestions for the record with respect to how to get more providers in rural health care, because you can have the facilities, don't have the providers. That's that. So, Mr. Chairman, I think it's been a really good, really important hearing. People know I have very, very strong feelings, which I will not express again, which will please the chairman, about how damaging these Medicaid cuts would be. We can get a bipartisan package here. This is doable, a bipartisan product in a crucial kind of area. Looking forward to working with all of you and with Chairman Hatch and all of my colleagues on both sides of the aisle. It wasn't a bad question in the House today, so we've got a lot of work to do. Looking forward to working with you, Senator Roberts.
Thank you, Senator Wyden, and thank you all for your attendance and your participation today. This was, in fact, an important and very helpful conversation. All of us look forward to working with each of you in a bipartisan way, both sides of the aisle, as we continue to work on a path forward to improve our rural health care for all of us who are privileged to represent rural and small town America. Dr. Mueller, let's see, it was 1993 that you testified before me, I guess, and now here it is 2018, so I look forward to hearing you in 2033 when I hope we have these things settled. I ask any member who wishes to submit questions for the record to do so by the close of business on Friday, June 8th. With that, this hearing is adjourned. Thank you so much.